Welcome to Shades of Radiology. Today we are going to discuss an interesting respiratory system case. 44-year-old female presented with cough and dyspnea since 14 months. So initially chest X-ray was done outside which showed few patchy opacities in the periphery of the bilateral lung fields. So the clinician has advised a CT scan of chest to look the extent of the involvement and the pattern of involvement. So these are the axial CT chest lung windows. What you can see here, I have given two images, that is the upper lobes and lower lobe involvement. You can see multiple small cystic spaces. So where are they located? Subpleural. Check out, they are subpleural in location, and you can see thin reticular opacities between the cystic spaces. You can clearly observe here there are thin reticular opacities and minimal ground glassing. Some amount of ground glassing is present. So this presence of cystic spaces, subpleural location. The few more sections, you can see again few more cystic spaces, reticular opacities, which are very much clustered and are closely opposed to each other. You can see again there are in the subpleural location. You can see, and this is the sagittal image. You can see the subpleural location of the honeycomb cysts and the linear reticular opacities. So based on these features, presence of cystic spaces with reticular opacities which are closely spaced, subpleural in location, involving bilateral lung fields with apico-basal gradient is a feature of UIP pattern. So the diagnosis is UIP pattern. So should we stop with UIP pattern? No. So we need to check for one more finding which is important here. Always try to look, once you have seen the lung, look for the chest wall and other mediastinal structures. So what is this? This is a dilated esophagus. Even here you can see there is some amount of dilatation of esophagus. This is another section showing again the dilated esophagus. So there is a dilated esophagus with UIP pattern. So what is your diagnosis? It's UIP pattern, possibly due to the scleroderma. I am telling possibly because it has to be proved serologically. So let us see what is UIP pattern. The salient features of UIP pattern is, the main thing is it's a pathological pattern of interstitial lung disease. And previously UIP was used synonymously with IPF, but nowadays it's not used. Let us see why. Because the UIP pattern is present in various diseased conditions. So there are various causes like connective tissue disorders, rheumatoid arthritis, mixed connective tissue disease, polymyositis, amiodarone lung, and chronic hypersensitivity pneumonitis and scleroderma like in our case. So there are various causes of UIP pattern. Whenever once all these causes are ruled out, or when you have completely excluded that there is no any cause for this UIP pattern, then it should be labeled as a idiopathic pulmonary fibrosis. So this is the reason why nowadays we don't use IPF in synonymous with the UIP pattern. So let us see what American Thoracic Society has given the clear-cut guidelines regarding the UIP pattern. So UIP pattern, they have classified into classic UIP pattern, possible UIP pattern, and inconsistent with UIP. So what is UIP pattern? All four features should be present. That is subpleural and basal predominance, reticular abnormality, honeycombing with or without transaction bronchiectasis, and absence of features of this inconsistent with UIP. Not even a single feature of inconsistent with UIP should be present to call it as a UIP pattern. Coming to possible UIP pattern. So what is possible UIP pattern? All these three features must be present. That is 1, 2 and 4 with absence of honeycombing. So you see all the 1, 2 and 4 of UIP pattern, but you don't see the honeycombing, then it is a possible UIP pattern. Then what is inconsistent with UIP? So if these 7 features are present in the CT chest, it is inconsistent with UIP. So what are these? That is the upper or mid lung predominance, pre-bronchovascular predominance, extensive ground glassing, like in our case there was a minimal ground glassing with extensive honeycombing and reticular abnormality, profuse micronodules which are usually bilateral and upper lobes, then it is inconsistent with UIP. presence of discrete cysts, that is multiple, bilateral or away from honeycombing, diffuse mosaic attenuation, and consolidation. So if one of these features are present, then it is inconsistent with UIP. So these are the and the American Thoracic Society guidelines which are given a clear cut for diagnosis of UIP pattern. So before ending this case, I wanted to know everyone what is honeycombing. It is nothing but a destroyed and fibrotic lung tissue, which contains numerous cystic spaces. So on radiograph, usually honeycombing appears as a ring shadows, usually of small 3 to 10 mm diameter with 1 to 3 mm wall thickness. On CT, they are closely spaced, clustered cystic air spaces with diameter of 3 to 10 mm, and is honeycombing is usually subpleural, and it is characterized by well-defined walls. So this same feature is present in the UIP pattern. Then these presence of all these features we call it as honeycombing. So the most important point and slide in this video is this slide, which has been clearly given by the American Thoracic Society. Kindly remember this. So next class we are going to discuss an interesting case. Thank you.